So I think the main challenges that we see in improving CD34 selection, as I said, is delayed immune recovery. So the approaches we're using there are using a nomogram to adjust ATG dose based on the patient's weight as well as the absolute lymphocyte count. And we're now giving the ATG before the conditioning regimen as opposed to during the conditioning regimen. So we think actually the in vivo dose of ATG that the graft is exposed to is much lower, and that may decrease some of the complications. What else can we do? One of the strategies that we're doing currently is also working with a company called Smart Immune that has licensed technology from a French group using prolymphocytes. And the idea here is that you can basically take CD34 stem cells and through not signaling ligand stimulation through DL4 and a series of different cytokines and chemokines, you can actually generate prolymphocytes from the donor, from the CD34 graft. And when you infuse those prolymphocytes into the recipient, what we've shown in preclinical models and what they've shown as well is that those T cells are then tolerant to the host and do not cause graft-versus-host disease, but do increase thymic repopulation and early immune recovery. And so the idea in this clinical trial is that we're going to take the donor stem cells, most of it will be CD34 selected for a graft, but a subpopulation will be used for an in vitro culture to generate these prolymphocytes. These will be infused after the graft is infused, and then we'll be able to assess early immune recovery. And they have early data in SCID patients where they see the benefit, and we're now conducting the first trial in malignant disease where we hope to see similar results.